name's Simon Finfer. I'm a professor of intensive care medicine located in Sydney, Australia. And in this session, we're going to hear from people from diverse parts of the world working in different healthcare systems with different resources available to them. And hopefully we're going to give you some idea of things that people have done that have been successful in our shared goal of improving care of people with sepsis and reducing the morbidity and mortality from sepsis. I am not going to spend a lot of time speaking because I think we want to hear from the panel members, and then we will have a discussion. Please feel free to post any questions, comments you might have in the chat section. We will deal with them as we go along. So our first speaker is Daniela from Brazil. So Daniela, if you would like to introduce yourself and share your slides. We'll have about 3 minutes, possibly a little bit more from each speaker, and then get into a discussion.
Good morning, good evening, or good night. Thank you, Simon. I am Daniela Souza. I am a pediatric intensivist in São Paulo, Brazil. And now I am the president of Latin American Sepsis Institute. It is an honor to be a guest speaker at this important event. In the next few minutes, I will present some aspects related to decreasing sepsis mortality and make gains despite social economic disparities. We know sepsis is a global health problem, and Latin American Sepsis Institute has been working to understand the real burden of sepsis in Brazil and Latin America. We work to recognize the challenge. In Brazil, Latin American Sepsis Institute coordinated 3 studies about epidemiological data in Latin America. LASI coordinate spread ICU, spread PED, and spread ER. At a one-day point prevalence study in a stratified pseudo-random sample of Brazilian adults, ICUs, and PICUs with follow-up to assess the national incidence, prevalence, and in-hospital sepsis mortality. In 2014, the study carried out in adults ICUs, the prevalence of sepsis was 30% and the mortality rate was 56%. In the pediatric ICUs, the spread PED carried out in 2019 showed a significant higher prevalence than in developed countries. The prevalence of sepsis in PICU in Brazil is 25%, and the mortality is 20%. At the other study carried out with a non-randomized ER sample in Brazil, the mortality rate due to sepsis was 30%. What draws our attention is that 40% of the patients who remain in the ER until discharge, 6% evolved to death. In Brazil, preventable factors such as incomplete or unknown vaccination status and healthcare association infections were associated with death from sepsis. And why is sepsis-related mortality is so high in Brazil and in Latin America? Reasons for this significant burden of sepsis may include lack of data on incidence and mortality. Now, LASI is working another study to evaluate the prevalence and mortality in PICUs in Latin America. Lack of knowledge about sepsis by the lay public and by health professionals, insufficient government funding for sepsis care programs, lack of adequate human and material resources, deficient primary health care, overcrowded and overburdened public health care systems. high rates of antimicrobial resistance, and social inequalities. LASI studies show how socioeconomic disparities influence sepsis outcomes in Brazil. Despite these efforts, LASI studies highlight factors that present opportunities for improvement. We believe that we can fight the sepsis by prevention, education, and awareness. There are several paths. We coordinated other studies that demonstrate you can do improvement in sepsis bundle by quality improvement programs that promote improve the adherence of bundles, reducing the time of recognition and reduce the risk of death. And so we need to work to reduce the healthcare associated infections and improve vaccination status. Brazil experts in these studies by sepsis epidemiology demonstrated that not only a diagnosis of disparities in sepsis program, but also a roadmap for visible interventions to reduce mortality even in coming countries. Thank you for your attention.
Many thanks, Daniela. And I see we're getting some comments in the chat. Please put any questions you have in the chat. What we're going to do is hear from each of the panel members, and then we will get into a discussion amongst ourselves and deal with questions that come in through the chat. So our next speaker is Ron from England. Ron, if you'd like to introduce yourself and tell us what you're up to.
Thank you so much, Simon. And hello, everyone. My name is Ron. I'm an intensivist, an adult intensivist in Birmingham in the UK. I'm also the founder and chief medical officer of the UK Sepsis Trust and one of the vice presidents of the Global Sepsis Alliance. So I'm going to tell you about the work that we have undertaken in the UK, which really describes a 15-year journey. And this is so important. We cannot change a region or a nation in 1 year. This takes concerted effort. And we've approached this from, as you can see on this slide, the perspective of public affairs. We've also approached it from the perspective of media engagement and engagement of the general public. So on the left, we have Jeremy Hunt, our health minister, a number of years ago. It took some time to get ministerial engagement, but once Jeremy Hunt was engaged as a health minister, as you can see in this image, he took sepsis very seriously indeed, resulting in prioritization of sepsis by the NHS. And the image there in the center is our second national action plan for sepsis. We are now in the process of our third national action plan for sepsis. So it's been really important in a country which has a national health service to engage that national health service. And that came through multiple parliamentary papers, multiple advocacy efforts, representation by, for example, our ombudsman for the parliamentary and health services, and concerted effort and lobbying to get that level of engagement. And we continue that process. And slightly glibly, that can be seen in the right-hand image where our current Prime Minister, Sir Keir Starmer, was talking about British reform. And he was present at Reckitt and Coleman, who manufactured the antiseptic product Dettol. And as you can see there, the transcript of his speech, within his very opening remarks, he said, what an impact Dettol has made against sepsis, which was a slightly odd thing, but it just shows how much talk there is in Westminster within our parliament around sepsis and around the importance. Now, we are best known in the UK and perhaps internationally for our clinical tools, our clinical products. So my team and I created the product, the Sepsis 6, back in 2005, 2006, with the brief that it interpreted the Surviving Sepsis Campaign guidelines, but made them accessible to every health professional, not just those in the intensive care unit, not just those in ED. And so we created this empowering tool to be delivered within the first hour of a patient becoming critically unwell. And that's disseminated widely across the the UK rather. And importantly, it's also formally endorsed by our NICE, our guidelines group within the UK. So they recommend that hospitals, our regulators recommend that hospitals, as well as other healthcare facilities, deliver on the sepsis 6, deliver on red flag sepsis. And we also have similar products for other services. So community-based services, hospices, palliative care units, ambulance services, general practice, dental surgeries, all of these areas we have clinical tools around. With the result that we have achieved change. And this slide is from 2016 to 2019. It describes the rate of administration of first-line antimicrobials, as well as the rate of screening patients for sepsis within English hospitals. These are not UK data. And they show that we went from a baseline of 32% of patients receiving antimicrobials within 1 hour to a peak in 2019 of 80%. And this is not cause and effect, but you can see that 3 independent reports assessing mortality from sepsis in the UK appeared to suggest, and this is in line with the New York State data, that mortality reduced from about 30% to about 20% during that time period. And it was importantly without the adverse consequence of increasing antimicrobial prescribing. The data at the bottom there are from our Royal Pharmaceutical Society, and they show that although antibiotic administration in terms of doses delivered in emergency departments increased significantly during this time period, total hospital administration of antimicrobials on the right-hand side, including in the emergency department, did not change hardly at all. Yes, of course, 0% would have been better, but the data show that we can incentivize better sepsis care without increasing the use of antimicrobials. And in terms of public awareness, now, yes, we are a high-income country, but none of this marketing, none of this advertising is paid for activities. We simply form relationship services in the UK, and more than 90% of our ambulances across the UK carry sepsis messaging. Big sports clubs, big retailers talk about sepsis to their public. Of course, we undertake media engagement activities, usually telling stories around people affected by sepsis, as in the bottom left. In the center bottom is a milk carton that was distributed by one of our retailers, Iceland Foods, and they've sold 100 million milk cartons with sepsis messaging on. Did not cost them anything because they print the labels anyway, did not cost us anything. And in the bottom right, we have our Schools Against Sepsis program with Hollywood actor Warwick Davis supporting this. This is now in place in more than 3,500 schools across the UK. But as we move forward into 2025 and beyond, we have to do so much more. We have just relaunched an all-party parliamentary group on sepsis. It has more than 130 parliamentarians registered to it. It is the largest all-party group in the UK, and we're going to be using it to push for parity between sepsis, antimicrobial resistance, and other acute conditions like stroke and heart attack. We should no longer be the poor relation of those conditions. Sepsis has to be afforded the same priority. Thank you so much, Simon, and thank you for listening, everyone.
Thank you, Ron. That obviously you've been working very hard for 15 years, and possibly you're ahead of many, many people, and we have much to learn from you. And I think that's quite a nice segue into Caroline, who obviously I know very well, and who being also from Australia, and she's going to tell you what's happening here.
So my name is Carolyn Hullick. I'm the Chief Medical Officer at the Australian Commission on Safety and Quality, and I'm really proud to be here talking about our Australian National Sepsis Program. In 2017, the George Institute wrote the Stopping Sepsis, a National Action Plan. And since then, the Commission's been working closely with the George Institute, and that plan asked for a National Sepsis Program that I'm going to tell you about today. So our Commission's role under legislation is to improve better health outcomes and experiences for patients. And we do that by leading national improvements in safety and quality. And when I think about change from a government perspective, I think about the many different ways that we can actually pull levers in order to improve health outcomes. So for us, we have national standards, indicators, outcomes. We monitor, we collaborate, we undertake research, and we consult. So for sepsis, we started working on the National Sepsis Program, and the first thing the first piece of work in National Sepsis Program 1 was around developing a clinical care standard that we developed in 2022. So all the work that's undertaken by the Commission is, because Australia is a federated country, all the states and territories plus the federal government have to agree on the outcomes and all the work that we do. So it was quite a lot of negotiation and thinking in order to get the National Sepsis Program. This means from a standards perspective that when hospitals are accredited, they need to meet the clinical care standard for sepsis, as well as antimicrobial stewardship. So the sepsis clinical care standard has 7 statements, and it's written from the perspective of the patient, the clinician, and the health service. And all of us have different roles in order to deliver excellent sepsis care. So the first one is around, could it be sepsis, getting people in emergency departments, but wards and the community to be thinking about, could this patient have sepsis? Then time-critical antibiotics is the second statement. The third one is around antimicrobial stewardship and making sure that, as well as giving antibiotics within 60 minutes, as Ron referred to, but also making sure that at 48 hours we're actually reviewing those antibiotics and making sure that they're not continuing if they're not necessary. But the rest of the sepsis program is around multidisciplinary care in hospital, patient and carer education. Many of the sepsis survivors tell us that we don't use the word sepsis when in hospitals, and that they would actually like to have known that they had sepsis. And then that transition from the hospital into the community, and then care after hospital, and also support for families who may be bereaved. So Sepsis 2, which is where we're up to now, I think has had a really strong partnership with patients and survivors of sepsis, and it's been a really important part to have them in every part of the work that we're doing, from the oversight group into each of the streams. And the 5 streams of work, one is the National Sepsis Awareness Program, and they have a tongue twister but basically talking about listen, look and act, could it be sepsis? The second one is around improving education and bundles of education, both for undergraduates and graduates across the health system. And we've been really focusing on primary care. The next part was around coordination of sepsis care. Again, many clinical specialties have care coordinators in hospital, like we have a very strong breast care coordination system in Australia. And the idea was that we should also be thinking about the sepsis coordinator in hospitals as well, but also someone to come back to and someone who knows about them when they leave hospital. We've been working on data tools for quality improvement. One of the challenges we have in Australia with our states and territories is just everyone speaking the same language around data access. So we're trying to standardise that, and we've done an epidemiology report looking at sepsis across Australia between the 2 programs. And then probably the most important thing we're doing is improving recognition of sepsis in Aboriginal and Torres Strait Islander people. I think that we do know that there's higher risk of sepsis for our First Nations people, and I think as a community we really need to work on that and ensure that we can do better, I think. So thank you, Simon. That's the Commission's website and YouTube account. All of our resources are free and available to the world. So I'm happy to be contacted, and happy for you to go online and look for our resources.
Thanks, Caroline. We're going to go back to Europe now, and we're going to hear what's happening in Switzerland from Nora.
Yes, thank you very much, Simon. Good afternoon. My name is Nora Lüthi. I'm an adult intensivist, and I have the privilege to be the medical program manager of the Swiss Sepsis Program, which is the Switzerland's first nationally coordinated initiative to improve the prevention, recognition, and management of sepsis. So like many other countries, Switzerland faces a significant challenge and burden from sepsis. Yet until recently, we lacked a coordinated and national approach to tackle the problem. And that started to change in 2022, when a large panel of sepsis experts, clinicians, policymakers, and patient representatives came together to create our first sepsis national action plan. And the document outlined the key actions and priorities needed to reduce the impact of sepsis on patients and our society. But of course, one of the biggest challenges remains. So how do we move from policy to practice? And we were fortunate that within less than a year, the Federal Quality Commission provided funding and allowed us to turn the recommendations of the action plan into a fully funded, structured 5-year quality improvement program And the program is clinician-led and it focuses on key pillars. So we want to improve public awareness, education and training for healthcare professionals, introduce clinical standards and pathways, and benchmark and evaluate the program, including the development of a national sepsis registry. But one of the most important success factors for programs like this is multidisciplinary and transdisciplinary collaboration. And in Switzerland, we face some very unique challenges. We are a small country, but we speak 4 national languages. Our healthcare system is highly decentralized and federal. And there's no legal mandate or central authority, so we can't tell people or hospitals what they have to do. That's why for us, collaboration is not optional. It was always essential. So we had to work closely, and we will continue to work closely with organizations and initiatives that are already active in the field, nationally and internationally. And this allows us to move a bit faster and to accelerate our process, to co-develop things like clinical standards and training modules, but also to come up with a coherent public awareness strategy and learning from successful initiatives. So our approach also needs to be flexible. We have to be adaptable for local realities, and we want to engage healthcare institutions very early and to offer our support during the implementation, and we aim to make benchmarking a tool for learning and implementation rather than just to measure compliance. So what have we learned so far? First, don't reinvent the wheel and learn from others and build on the successes elsewhere. Third, we really want to involve patients, and we should involve patients and the public from the very beginning, but at every stage of the process. And we continue to build strong alliances nationally and internationally to share our knowledge and best practices, to benchmark and evaluate what we are doing, to give us sustainability and accountability, and also to show if and what impact we are going to make. And finally, we believe that a structured action plan with clear goals can really open doors to funding and policy change and to support needed to turn vision into the systematic and systemic change we urgently need. Thank you very much.
Many thanks, Nora. Now we have a change in panel member. Vida Hamilton was going to talk to us about Ireland, but unfortunately she couldn't make it. But we have a very able substitute in Sue. So Sue, I'll hand over to you and you can let us know what's happening.
Thank you, Simon. So I'm an assistant director of nursing working in the National Sepsis team. And I work with clinical lead, national clinical lead, program manager, and 6 other assistant directors of nursing or ADONs, one which is working with Children's Health Ireland, and then the others working with the 6 HSE regions. Okay, so we have a national clinical guideline for sepsis management for adults, including maternity, and that was developed in 2014, courtesy of the Surviving Sepsis campaign. We revised it to reflect the Sepsis 3 definition in 2021, and we're currently in the process of a rapid update to reflect the current changes in the Surviving Sepsis campaign guideline. So we know that prevention is the best way to reduce mortality from sepsis. But the other way, I suppose the next most effective way then is early recognition and treatment. So in order for that to happen, 6 processes must occur, and that is that the unwell person, their family or carer, must be familiar with the signs and symptoms of sepsis and seek urgent medical care, that early recognition by healthcare staff and timely escalation to medical staff must occur. Treatment with the Sepsis 6 bundle, and courtesy to Ron and his team in the UK for allowing us to use that, and the reassessment of patients' response to that initial therapy, and also adequate critical care access. So in order for that to happen, there are 3 pillars, and that is public awareness, staff education and protocols, and hospital resources to support that education and that continued implementation of protocols. So in I suppose for the last 9 years, we've had a national sepsis report, and we get our data set from the HYPE, or Hospital Inpatient Inquiry System. So HYPE provide and collect data for us every year. And for the last 9 years, we've produced a national sepsis report. So in 2023, you can see the key findings there that we would have communicated for all regional healthcare areas. And there were 15,722 cases, documented cases of sepsis and septic shock in 2023, with a crude mortality rate of 19.3%. Now, that was reduced from 20.8% in the previous year. So our detection rate has increased while our mortality rate is decreasing. And you can see some of the other data there that sepsis in older people, 28% of people who died from sepsis in 2023 were age 75 or older, and over 30% of those that died had greater than 3 comorbidities. So we can see the effects of an aging population in our country. And I suppose when you look at the age standardized mortality rates per 100,000 in the run chart to the right, from 2011, we had 27% mortality rate over the years down to 19.3% in 2023. It has taken a few dips, obviously, and peaks and troughs, and more notably recently, the pandemic from 2020 to 2022, and we've come down below that 20%, even though 19.3%, as we all know, is still too high a mortality rate. The other thing that we also do is that we do process audits. The ADONs, I suppose, go to all the hospitals every year, and we do process audits. So we do annual audits every year for adult, maternity and paediatric audits in all of the hospitals. And we liaise with management, and we've interdisciplinary collaboration with each hospital site then to provide a team to work with us on auditing. So our process audits report on the key quality indicators, including 30-day outcomes identified in our guidelines, and we report those to senior management teams and to deteriorating patient committees, which exist in all hospitals. And then in terms of our HYPE data set, then that is, we publish a national sepsis outcome report every year, and that is annual, collecting the data, as I said, from the HYPE data set. We know then that we're improving our mortality. Have we achieved a reduction in sepsis mortality as we're discussing through system change? Well, I guess we have in the acute hospital system. We have a long way to go, and we know that, and we're doing a huge amount of work. And the next piece really is connecting with the community then to see how we can improve the awareness in the community and really promote better awareness. So what is happening for us in the public? We've had a huge social media campaign in the HSCE for the last year, and we had a month last year, and we've just had the month of March. And the key message from that is that sepsis can hide behind any infection, and to encourage people to watch out for the signs and not to be afraid to ask, could it be sepsis? So it's the same message that we're all giving across all healthcare systems, and that sepsis can happen to anyone. We also communicated with pharmacies and GPs with leaflets and posters with the signs and symptoms of sepsis. And finally, our current action on sepsis from 2025 to 2030, we have a 5-year sepsis strategy that we will be launching this year to address sepsis governance, preventing avoidable sepsis, increasing awareness of sepsis amongst the public and health professionals, improving identification and treatment across patient care pathway, improving support and care for sepsis survivors, and also, very importantly, research on sepsis. That's it. Thank you.
Many thanks, Sue. I think we are hearing some recurring themes here, which we'll discuss, which I think are quite universal, regardless of what sort of healthcare system you're in. And we'll hear from our last speaker, who is Direk from Thailand, who probably is in a slightly different healthcare system from some of us. So over to you, Direk.
Thank you very much, Simon. And my name is Direk Limmathurotsakul. I'm head of the Microbiology and Mahidol Oxford Research Unit in Thailand. First of all, I'm not the main leader for the sepsis program in Thailand. There are multiple key players in the country that lead the sepsis program. But we are working as a sepsis alliance in the country, and one part of it, I focus more on the general infectious disease, microbiology, epidemiology, and data. Thanks for having me to come and telling you about the story from Thailand. From my point of view, I want to share you a few points. One, I think that the strong side of Thailand is that we have quite good researchers and collaboration with the international program. And we try to do the research that fit in with our country. There are multiple, and you can see that the papers related to the sepsis in Thailand is increasing over time, but then during the peak before the COVID and now decline a little bit. But we hope that the people will come to do focus more on the sepsis further. And there are a lot of things that we have to try to do, that the things that are recommended international one is working in the country. The one that I help personally is better when we have a sepsis program in the country. The reluctance are always that we don't have the ICU as good as in the high income countries. Many patients that define that as a sepsis still treated in the general ward. Whether if we have the program and cannot take into the ICU, would it be a backfire to the people and to the hospitals? But our work try to support them and see that even if they have a sepsis program, they start the alert, they have the form, they have a protocol. If the patients cannot get into the ICU, it's still much better than not having the program at all. So that's some of the work that we have to do and related to that. So I think that is one of the pillars that's supporting the sepsis in the country. And as I said, there are a lot of people working in that, and it takes multiple years, at least as far as I know, 3 to 4 years to work with and do the policy engagement. And they took it into the national program we call it service plan, which is big part of the universal health care in Thailand. And I hope that you are aware that Thailand is quite famous for the good universal health care system that is literally free. But even that, if the patients get the sepsis, they will have to come from their house to the small hospital before they get the free treatment and got transferred to the hospital level that they have a facility and manage as much as possible. But even that, within the service plan, we call service plan, sepsis is formally integrated into the plan of the universal health care. Is one of the indicator, and they have the aim to go into the reduced mortality of the sepsis. I'm not planning to ask you to read Thai, but I highlight in the way that you can see that it's literally there, and they use all things, Q, SOFA, SOS, Muse, whatever it is. But then once it's integrated into the universal health care key performance indicator, KPI, the things that related then come to the challenges that how we are going to monitor whether the mortality of the sepsis really going down for the whole country in a low middle income country. That's not easy at all. And at the moment, they are using the ICD-10 as a system. They cannot use the registry because they cannot go for the whole country. And that's a system that cannot move that fast. But the data that ICD-10, if you are familiar with ICD-10, some are good, some are quite difficult. And that's the difficulty to monitor the sepsis mortality so far, even it has been implemented for 8 years. There are a lot of studies in the university hospitals, that's okay. But going to the whole more than 100 public hospitals in the country, that's still big challenges. And similar to many other low-middle income countries, even it's free, but we have limited GDP, we have limited budget. Obviously, we have limited resource, number of doctors, ICU bed, patients get into the ICU, cannot get out if they cannot sit up. So then the ICU occupancy is always 120%. And even they implement fast track into the system, how to implement to the multiple levels hospital in the country is still a lot to go. How to implement even just a simple lactate into the community so that the patients can transfer to the bigger hospital faster is still a push at the moment. And I think awareness among the healthcare workers, doctors, nurses, and in the alliance of the healthcare, I think they are good. But for the public awareness, is still the alliance start a lot of work, try to push a lot, but I think it's still a lot to do. And even just the simple things that we have to debate. Should we call it sepsis, or should we have a Thai word to mean sepsis? Just that kind of it is a big debate in the country because the word bloodstream infection and the word severe infection has been used for so long among the lay people to have the idea of the sepsis. But at the end, they push into the word just sepsis like this for Thai people. But again, if the campaign is not big enough, it's still a long road to go. And that's I want to share. Thank you very much. Back to you, Simon.
Oh, thank you. And thank you to all our speakers. We have a few questions. I think just if I risk summarizing that all very simply, if you like, I mean, the themes are ones that I think we're all very familiar with, and possibly all the people listening are very familiar with. One is the awareness issue. I should say I am the director of Sepsis Australia and the Asia Pacific Sepsis Alliance, but obviously the George Institute for Global Health that Carolyn talked about. I lead the sepsis program there. So, and we've surveyed an Australian general population on 2 occasions now, and we still have less than 50% awareness of what sepsis is, even the word, what does it mean? And still a very low percentage of people who actually can describe any of the symptoms. Fever and shivering gets to around 20%, and everything else is very poor despite our best efforts. There was a question which leads, I guess, to a question to Ron, was how are you measuring the effectiveness of your awareness campaign? Well, you already have a very high awareness, so I guess that's maybe, apart from measuring the effectiveness, how have you managed to achieve this incredible level of awareness? I mean, you've told us some of the things. Can you give us any more sort of practical tips to people around the world? I mean, it's all very context specific, but it'd be interesting. I think you've achieved something that the rest of us envy.
Yeah, well, thank you, Simon, and that is kind. And I think it's fair to say that typically in these sessions, there are people from the United States preceding me. So I am guilty of using the great headline figure to show how great things are. But 96% of our public can describe sepsis. So they know what the word is, and they can describe vaguely what it is. Slightly smaller percentage, 91%, would behave in the right way if they were worried about sepsis and access healthcare immediately through an A&E. But it is only 37% can describe the symptoms with any reliability. So we still have a way to go. And to Michael's question, this is, as you do, through continuous surveys, but we try to assess human behavior with our surveys rather than just awareness of a word, which doesn't really change much. The message to our potential sponsors for public awareness is always use your existing dissemination strategies to get the word out to as many people as possible. Now, the example was the milk bottle with the food retailer. The example was Liverpool Football Club's website. And we do similar with other agencies. Some disseminate messaging internally, some disseminate messaging externally. We have to give to these organizations before we can hope to take from these organizations. So it's a responsible health and well-being message. It's a responsible safeguarding message for their staff. And usually when we do the design work and they have the resource and dissemination strategy, it's a good partnership. Engaging the media is critically important. And it's very difficult to do that with resource. We have in-house public relations people, in-house communications experts, and we are very good at engaging the media, but that doesn't happen accidentally. That happens extremely strategically. So I think it is important that we educate the public. It is important that we collate people who've experienced sepsis and encourage people who've experienced sepsis to share their message with the media. It can be done, but I wouldn't pretend it's an easy thing to do.
When you say give to people before you get something from them, can you elaborate? I mean, that's basic human nature, I guess, but can you elaborate a little bit? I mean, what did you give to the milk bottle?
Yeah, so a good example. So Iceland Foods, it's a major food retailer. It deals with the lower end of the socioeconomic spectrum. So it deals with predominantly single parents, people from diverse ethnic backgrounds, people on lower incomes. Critical groups to get our message out to. So their finance director lost his father to sepsis. We approached them and said, can we help you to educate your clients, your customers around sepsis? And of course, being a finance director, he didn't want to spend anything. So he just put messaging on something he was going to print anyway. But since that time, and mindful, not everybody is a charity. We are a charity, so we need income. Iceland Foods have raised over £500,000 for us. So we give to them. Downstream, they support us and give back and help us to do more good.
I think that's actually the fact of having personal involvement with an individual seems to me, and I'm going to try not to talk too much because that's a serious fault I have, but we did have questions about how do we engage government. There's a question about at what point did the government become involved in Australia? And I think I'm going to address that myself because Sepsis Australia and the George Institute, I mean, we were very fortunate that we have a government relations department because we're not a sepsis organisation, we're a public, global health and public health research institute. And we have people, in fact, the person who got us engaged with the government is now actually an MP. So he was very well connected within government circles. But what really swayed the Minister for Health was the fact that two of his own constituents, which was a GP and his wife, they lost their pregnant daughter to sepsis. And it would be fair to say that the management fell below the standards that we would expect. And because they were his constituents, they were constantly knocking on his door, saying, what are you doing about sepsis? What are you doing about sepsis? What are you doing about sepsis? And I do think people who have survived sepsis, people who are bereaved by sepsis are our strongest resource. So that's what led to us getting the money, although we've been advocating for this for some time without success, with access, but some success. That engagement and it's very hard. We have something called the Sepsis Australia Consumer Partner and Advocacy Program, which is a group of more than 60 people now. There's a group of them who've all lost limbs from sepsis, as we all know that happens, and they call themselves the Quad Squad because they're all quadruple amputees. And if they appear in Canberra or in front of Parliament with journalists, the media, as you say, it's kind of a hard thing to ignore. The question was also, I think the question, it shouldn't, I've witted on about Australia, was also about the government, in what way was the government involved in Switzerland? And we've heard from Direk that a service plan is a KPI, the sepsis KPI in Thailand. That's possibly, so maybe all countries are different and organized differently, but is there maybe Nora, Direk, and Daniela, I think you've been trying to engage, and I haven't got a clear idea of how successfully in Brazil. How do we get government to take notice, given that everybody's knocking on the door saying our disease is the worst one that you've got to devote resources to? I'll just make life easy. Daniela, then Nora.
Unfortunately, in Brazil, we don't have a national plan for sepsis. LASI tried to work with government, but we don't have this plan. Only in São Paulo, we have a mandate for sepsis, but the government don't check if the hospital have protocols for sepsis. We would like to have a national plan, but we don't have. And I think in Latin America, no have the plans, governments for sepsis.
Well, Nora, you've been very successful in getting money that we're all very jealous about. Was that easy, hard? How did it happen?
As I think I mentioned it already, but from the very start, we had representatives from the Federal Quality Commission on board. So one of the representatives from the Federal Office of Public Health, she actually recommended to invite a member of the Federal Quality Commission to the first workshop. And I think that was a very intelligent way to actually showcase or to already show people in the commission and in the policy that you can engage people. And having such a large panel with all relevant stakeholders already at the workshop, and then having an action plan endorsed by multiple societies, really gave the impression to them that we are able to move things. We are able to come up with a plan and have an idea what is needed. The timing was also just right. So sometimes it's also luck, because the Quality Commission was established in 2021. So this is really a new commission, and we have a new Health Insurance Act that you have to register, and have to come up with new quality assurance measures in the hospitals. So it was just a very nice fit, that they could see that such a program could have an impact on the patient safety and quality beyond sepsis as well. And I think coming off the pandemic and having this newly established quality commission was just a very good a coincidence as well. There is also a bit of luck. Yeah. I
guess I've been asked that question a few times about how do we get, and you have to look at your own country. I mean, we're very lucky in Australia because we have Carolyn and the Australian Commission who have a mandate, federal mandate to improve healthcare and look at variances in outcomes and treatments across the country, and to write these wonderful standards, both accreditation standards, because they accredit hospitals, but also the clinical care standards. There are many, many resources. Clearly, Ron has lots of resources. The Commission's resources are free. You can go on, you don't have to log into the Australian Commission's website. You can just go onto the website. And obviously it's all in English, which might be a challenge for some people, but all those resources are there. So, Direk, you've got your hand up, and then Sue.
I would like to raise 2 points for the low middle income countries. And from our experience, if you don't have the commission or committee, I think form your alliance. I think it's so crucial. You don't go to talk with the policy makers alone. The stronger your alliance, the variations of the team that you pull together and get the consensus among yourself first before you go and talk with the Ministry of Public Health, that would give you the message across much better. The second, I think that most of the policymakers in the low middle income countries don't want problems, they want solution. So when you form the alliance, you should have the consensus about your potential solution that you want to propose to your policymakers. You need to have some plan agreed among our committee or your alliance first, that we want this program that is super cheap, going to work, to be implemented, and try to go it step by step, rather than try to ask them to do the campaign and put into the tele. I think that would come later. So that's our experience, and I think that it might be helpful in some countries as well.
Yeah, I think that's important, because we have had questions in the chat about how do I organize an awareness program for an uneducated community, and how can this be done how can we capture sepsis in rural areas where there's no electricity to create databases, etc. I mean, these are enormous challenges. I'm not sure, I certainly don't have the answers. So Sue, and then Ron.
Thanks, Simon. I think sometimes as countries we can be reactive rather than proactive. And I know we've had some very high-profile tragic cases where people have died and young people have died. And quite rightly, we react to that. But it can't just be reaction all the time. And sometimes funding then comes based on that reaction. And that can be a problem. So funding needs to come to help us to be proactive, rather than just reactive. And I think sometimes that's what can happen in healthcare systems. And you get government buy-in then sometimes with the high-profile tragedies, which is quite rightly so, but it shouldn't just take a tragedy for people to invest in the healthcare system to really try and promote good sepsis recognition and treatment.
Yeah, no, that's very true. I guess one of our goals has been to kind of have things, as we say in English or Australian English anyway, shovel ready, so that if an opportunity comes along, we're available, and we have resources aimed at, for instance, philanthropy. We don't have a strong philanthropic sort of culture in Australia like in the US. The US has much more of that, but we are ready if someone does want to give, it shows interest, or we want to go talk to someone, or we hear of someone, high-profile person who's had sepsis, we have the resources ready to go and talk to them if they're prepared to talk to us. So, Ron, you were...
No, thanks, Simon. So it was 2 quick points. It's now 3, but in less than 2 minutes. Firstly, to Ryan Mudassar from Sudan, I think, this can be done among uneducated communities who perhaps can't read and write. Have a look at the work that was done in Burkina Faso, the small African country, where they had a successful radio campaign around sepsis that resulted in significant improvements in public awareness, as one example. There's been some work in maternal sepsis in Malawi. The second point, I agree with the points just made. When Jeremy Hunter, Health Minister, decided he wanted a public awareness campaign, we had one designed and ready to put on his desk, and it is so important that we do that. And then the third point relates to what was discussed around amputation, but also the non-visible sequelae for survivors. It's really difficult to persuade governments to invest first in survival. Our perspective is first we have to invest in creating reliable recognition and immediate care. But, just to reassure, we don't ignore survivorship. So our charity is one of the only ones globally that provides direct access to support nurses. We're not the only one, we're one of the only ones. So we have support nurses, psychotherapists, counsellors, all available to people who survive sepsis or been bereaved. Thank you.
Thanks, Ron. Carolyn, I'm an enormous fan of the clinical care standards, not just for sepsis. Can you maybe say something about the other, you've said a little bit about the structure, which is the clinical care standards organized in each statement in 3 sections, which I would summarize as what should the patient expect when they go to a hospital with sepsis, what should the clinicians do, and then what should the healthcare organization provide so the clinicians can do what they need to do to provide what the patient should expect to happen. But there are also a lot of resources around compliant, more than just those statements and then leaving it to everyone to do it. Do you want to say anything more about that?
So each of the statements have got a clinical indicator that's attached to them. We've got 19 clinical care standards now. One of them sepsis, one of them's antimicrobial stewardship. We choose them based on being high prevalence, high risk conditions across the community, but they're linked into our national standards. So the first standard of our national standards is clinical governance. So when hospitals are accredited against the standards, they're expected to demonstrate that clinicians have got access to evidence-based guidelines and evidence-based practice, and they're required to demonstrate their program of work around the clinical care standards. So I think by linking the clinical care standards not just as a standalone guideline, but linking them to the national standard, I think that's been really powerful. I think as a clinician, we often know the right thing to do, but I think the power of the clinical care standards is actually talking about what the health service organisation needs to do in order to support me to deliver excellent care in the emergency department as an emergency physician. So if I need to give antibiotics straight away, do the nurses know how to draw it up? Have we got access to the right medicines? All those systems and processes, things that we take for granted that we actually need in order to deliver time critical care.
Yeah, I think they're very different from guidelines. Guidelines say you should do X, Y, Z, whereas I think there's so much more to it, and we've heard. I mean, really, the 3 themes I think that run through all this are awareness, education, and resources. And obviously, some of us are more lucky than others in terms of the resources that we can draw upon. Although I don't think there's a healthcare system in the world where people think they've got everything they need. There's a question which is an interesting one about partnering with other organisations, and I think as Direk said, and this is something we've tried to do at Sepsis Australia with differing levels of success with different parts of the kind of specialties within hospital medicine. I think, and that's an interesting question, maybe it would be interesting if people would, who are the key people to partner with? Is maybe because the problem, I've always envisaged sepsis as being this problem, this really difficult problem, because apart from the fact that we have no diagnostic test, we can't take a biopsy, and which makes a registry very difficult because the diagnosis and the diagnostic criteria themselves are difficult. But as I try to explain to people who are mystified about this fact, why do we need these something like Sepsis Australia? I said, well, the problem is if you come to the hospital with pneumonia, you're treated by a respiratory physician, and if you come to the hospital with a gangrenous gallbladder, you're treated by a general surgeon, and if you come to the hospital with a skin or soft tissue infection, you might be treated by someone completely different. And therefore, we have to educate the entire healthcare system, which is a challenge. But maybe who would be the key people? Who wants to offer an opinion on who are the key people? Otherwise, I'm going to pick on someone. I mean, Ron's going to put his hand up because he's but. I mean, I'm interested for Daniela. I've been to Brazil, and I think I surprised everybody when I was in Rio, because I didn't want to go up the mountain and to the statue of Christ and stare at Christ. I asked to go to a public hospital emergency department, and to be quiet, I was, as you said, 40% of people with sepsis, they don't leave the emergency department. And I think you said 60% of them leave the emergency department by dying. And certainly the hospital I visited in Rio, there were people ventilated in very crowded circumstances in the emergency department. It appeared to be nobody dedicated. I mean, we have one nurse. Every ventilated patient gets their own nurse. That's certainly not the case in that hospital that I visited. So in your system, who would you think were the key people to try and get on board to improve, particularly in the public hospital system?
I think we need engaging people about sepsis. We need work about education. And I think these numbers that I present are underestimated, because at COVID-19, we lost a lot of people without the healthcare systems. And I think it's very difficult, but we need educate. I think education is the key of the success. And we have another question about how to improve the results about sepsis. And Lüthi has a very nice experience about quality improvement programs. And I think quality improvement programs is like education. But here at rural areas in Brazil, we don't have the electronic registers data. You need to work in this, but I think education.
And is LASI predominantly an intensive care-based organization, or do you have people from other parts of the healthcare system?
No, we work without ICU. Our epidemiological studies is ICU and ER, but at the quality improvement program, we work with sepsis teams, and the sepsis teams involve physicians from ER, WARM, ICU. We work with nurses and pharmacists, infectologists, and other colleagues. And we work at the public and private hospitals. But Brazil is a very, very big country, and it's so difficult to involve all country.
It seems to me that in most places it's been intensive care people who have taken them. We're going to go for about another 10 minutes, and then I know Ron may have to leave before that. I'm not sure if he can hang on for 10 because he's busy saving lives at the moment. I'm staying out of the hospital. That's how I'm saving lives. I just wonder if one issue we haven't touched on, which I think is really important, is that we talk a lot about, reducing death, etc. But we know there's enormous, morbidity associated with sepsis, and would anyone like to comment on work that, maybe. Obviously, for some people, this is not so relevant, but I think it's very relevant, is trying to improve the quality of survival for people who survive sepsis. I mean, in those countries where we've now got the mortality rate for septic shock down to the, mid to high 20s, that means 75% may be surviving, and that's those people often survive with quite significant issues. Does anyone want to offer any advice or on how they are or think they should be tackling that?
LASI now has a new program about survivals. If you go to LASI's website, we can go check the Rehabilita Sepsis, a program about rehabilitation for survivors, and you have a lot of videos and material to educate the survivors. Now we engagement in quality improvement program for sepsis at the hospitals and rehabilitation. It's a very nice program, and if you can check at the website, it's very nice and very interesting.
A lot of resource on our website that is free to access. So if people wished to use some printed literature to guide survivors, guide the bereaved, there's plenty of that on our website. But the only point I was, there's always going to be a resource associated with this, but we support several thousand families each year with just 2.7 whole-time equivalent nurses within our organization. So yeah, to do proper rehabilitation is prohibitively expensive at the moment for most countries and governments, but to provide support is not prohibitively expensive.
Yeah. Okay. Sue, then Nora, then Carolyn.
We would all love to be at Ron's stage of development in terms of supporting those survivors. So we're very much at the initial stages. And I suppose last year we had our 8th National Sepsis Summit, where we had an advocacy work stream. So that was a really good start that we've made, engaging with survivors, with parents, with advocates. So we've a long way to go, and we know that, but it's certainly part of our strategy. And we would love to be at Ron's stage where we have really good national supports for survivors or families of those who've survived as well. So,
and Nora, you had your hand up. It's gone, but
yeah. So I agree with my colleagues, and something that we also experience is that education is key here as well. So we had a workshop last week, and we had physiotherapists there attending, and she did not know anything about post-sepsis syndrome or post-sepsis care, that this would be a problem or could be a problem. And she was very much involved in, for long COVID, for example, rehabilitation. So I think education there is really key also for the primary care physicians, because we often hear from them that they don't feel that they play a crucial role in sepsis. And we have to educate them as well about the post-sepsis sequelae and what they can do to support patients, because I agree with Ron, we don't have money to support everybody in a rehabilitation program, but we can educate people and also educate health insurance companies. That's very important in Switzerland because we have a competitive health insurance system. So if they don't know about it, then they can't support patients that well. In terms of education, I think we can play a crucial role as well.
Carolyn?
I think Nora just stole my thunder, but I was going to say that our post-sepsis program has really been concentrating on engaging with the general practitioners, the primary care physicians, because often they're the first person or first clinician that the patients see after they've left hospital, and then the person's had a very complex care stay, and the GPs don't necessarily know what to do next and where to go. And as you've touched on, sepsis patients are cared for by many different specialties across the hospital, so there's not one clear pathway of where to go next. So I think, yeah, concentrating on primary care is really important for us. The other thing I was going to mention is that in our epidemiology report, there's 3 conditions, I think, that are standing out as a place where sepsis occurs more commonly, and they're people with diabetes, cancer patients, and patients with chronic kidney disease. And I wonder whether some of the places where we should be going next is to start to concentrate on people who are at a high risk of sepsis and start to be educating them on sepsis so that sepsis can be recognised earlier.
Sorry, I'm targeting those high-risk groups is probably what people refer to as low-hanging fruit. So, Direk.
Thank you, Simon. I would like to talk a bit about the point that related to the mobility. But I think that for the low middle income countries, about the alliance and what to do, I think that the point is try to relate that to the disease that are working well, the program that are working well in your own country. You might be able to check with it. For example, if I'm in Africa, I might think about malaria program, and I might need to find the reasonable persons within the malaria team to be included within the Sepsis Alliance. And if how the village health workers or the volunteers or people screen for malaria or come to check for the people for malaria, if they are malaria negative, what would they check for the sepsis, and how would they do the sepsis fast track for that? And I think that would be the key to start the cohort to improve the understanding. And to think about the mobility, I think that if the listener here are the young small person and want to start small, maybe start a study or the project that look into the mobility of the patients who survive for 1 month, 1 year, and try to do the focus group discussion, questionnaire, survey, and try to use a modern approach for the epidemiology and social science. I think that would be the good information for your own country to move it forward, because I think that is always true that the sepsis patients, when they survive, they have a big issues to go back to work, to earn their incomes. And even in Thailand, we have a big problem. They cannot go back to do the farming anymore. And it is a big issue. And I think that a lot of things can come from the small study and do this step by step and to improve your impact into that. That's what I want to convey. Thank you.
Yeah, I think that's a really great point about finding an effective program that you can piggyback onto or join with. I think that's a really, really important point. And it's a great comment. Thank you. Sue, we might have the last comment on this.
Thanks, Simon. Just further on from what Carolyn was saying, engaging with primary care. So we've done a good bit of work with the Irish College of General Practitioners in Ireland, and we have 2 GPs working with the National Sepsis team at the moment. So the first one has produced a guide for adult sepsis. So that has been launched for GPs, for use with GPs, a user guide really just to try and guide them in terms of assessing whether the patients have sepsis. And the second one is the pediatric one, which is being worked on at the moment by our second GP. So at least we're making, hopefully a good bit of progress in the community, as well as linking, because our HSE has changed now in terms of its structure, and community is very much coming in line with the acute hospital system. So there will be a lot of changes hopefully happening over the next few years with community and really engaging with them. So, but I think definitely primary care engagement is the key way to go.
Yeah, I think obviously on the Sepsis Australia website, we have a button for people to get in touch with us if they want to. And there are really the 2 commonest questions that come are firstly, my mother, father, brother, sister, child died of sepsis. And the first time I heard the word mentioned was when I saw it on the death certificate. And that goes to, the fact that we talk to patients about someone's got severe pneumonia or someone's, got dead guts or something, rather than actually mentioning the word sepsis. And the other one that comes is very commonly is that I or someone I love, care for, whatever, has had sepsis and is not well and can't think clearly and can't do their job, and I'm trying to get help, but nobody seems to know what to do or what's wrong with it. So that rehabilitation phase is really important. There is a question about, do we see a resemblance with sequelae in post-COVID, etc. I mean, I personally found the fact that that long COVID, everybody's heard of long COVID, and it's in the newspapers, and it's been enormous resources dedicated to it. And we have been banging on about post-sepsis syndrome for years and largely been ignored. So I think, yes, and there are, when someone's been sick with sepsis and been in the ICU, then a lot of the problems are common to critical illness of any sort, that sequelae of being ventilated, etc., etc. Whereas I think long COVID, often people have not been in the ICU and have not been that sick. And I think the same is probably true of people with sepsis, with the lesser things. But these are very, very difficult things to follow. Now, I'm going to say to the panelists, Carolyn's got her hand up, so I'll go to Carolyn briefly. But if any of the panelists think that we've missed out some important point, please put your hand up and I'll give you the opportunity to say whatever it is that we've missed out. Otherwise, we'll hear from Carolyn, and then I'm going to do a couple of thank yous, and we'll wrap this session up, which I think has been great. And it's been really good to have all the panelists engaging, which is difficult when we're spread across the world. So, Carolyn.
I was just going to mention something that I suspect some of you know a lot more about than I do, which is the 2030 Global Sepsis Agenda. So it has done some really good mapping about where there are strategic alliance opportunities for sepsis. And I think there will be some good learnings in there for people from low and middle income countries, as well as the rest of the world as well. So I'd encourage people to look at that document.
Okay, well, it's 9:20 at night here. We could go on all night, but perhaps we shouldn't. I'd just like to thank all the panelists for engaging and sharing their knowledge. Ron has had to disappear back to the ICU. I'd also like to thank, possibly invisible to the audience, Sheila Miatra, who has been monitoring and passing on questions from the chat to us. So many thanks to you for doing that, Sheila. Sheila, Ron and I were given the job of putting this session together, which was a daunting task, but I think, I hope it's been of help to people. And again, thank you to the panelists. Great job. And we all just need to keep working at this. We're making progress, and we will get better and better. Thank you all.